now we have two positive studies with PCSK9 inhibitors. We know that reducing cholesterol with the monoclonal antibodies, we can reduce cardiovascular events. But the great question that comes is how cost effective is this treatment? We know that in Fourier we had a relative absolute risk reduction that was from 1.5 to 2%. That means that we need to treat between 50 and 66 patients to reduce one cardiovascular event. And we know that the evolocumab has an elevated monetary cost. So how do we do in order to increase our bang for the buck here? Basically, I think we can learn a little bit from SPAR2. Despite the fact that bococizumab is no longer or will never be at the market, the study clearly showed that if you have a higher LDL cholesterol, because the average LDL was 130 milligrams per deciliter, actually you can get a greater benefit. And if we consider this and when we extrapolate to the results of Fourier, where the average LDL was around 90 milligrams per deciliter, one can think the following. So, which would be the highest risk patients that would get the best benefit? Because it's totally clear that these drugs really prevent cardiovascular events, but which would be the best patients? First, I think it has to be a very high risk patient. So, okay, who are these patients? Those who already have cardiovascular disease, number one, so a secondary prevention. Those who have higher LDL cholesterol levels despite the use of statins and ezetimibe, because we have to maximize the current treatments that we have. Third, we have to consider other situations that might increase the risk in a patient who already has cardiovascular disease. So probably diabetics, those who keep smoking, and those who had a recent acute coronary event. Because we know from many epidemiological studies that those are individuals that have a higher degree of risk. Certainly, we'll have a sub-analysis of Fourier that actually will really study these subpopulations and to really, for us to have a more real evaluation of the impact of treatment. And finally, I like to say that we always come back to FH. Because what happens if you have a patient with very high LDL who already has cardiovascular disease, I think most of these individuals actually who are refractory, right, to the treatment might have familial hypercholesterolemia. So I think cholesterol and risk are the key. So you have to get the whole environment of risk, but consider cholesterol as really the main driver of identifying those higher risk patients and to treat those patients very aggressively, because we're going to have a bigger LDL reduction and we're going to have